Hello everyone, this is Dr. Garima Sachdeva and today we'll be discussing about vulval cancer. So we'll be discussing about the most common type of vulval cancer, that is squamous cell carcinoma. The second most common, which is melanoma. We'll be discussing about the phago staging, the investigations which have to be done, and how do you manage stage-wise management of these cancers. So stay tuned, mostly you will find it helpful.
So vulval cancer, most common type is squamous cell cancer seen in 90% patients. Mostly it is unifocal and the most common site is labia majora. So all these three are SPAs. Okay. Then second most common type is melanoma. And
Unifocal is confined to one side.
unifocal is at one only confined to one side. Multifocal at multiple sides.
Okay.
Then second most common is melanoma. What percentage of squamous cell carcinoma are associated with high risk HPV, that is 16, 18, 31? So it is 25 to 30%, and mostly if it is associated with HPV because it's an infection, so then it occurs in young population and multifocal. If it is associated with other reasons like lichen sclerosis, then it is unifocal and occurs in elderly people.
Okay.
Okay, what percentage is dedicated to lichen sclerosis? So 25%.
Okay.
Then risk of developing invasive disease in women with lichen sclerosis is 4%. Okay. So if you are suspecting, like in an OPD, if you see a patient, there is a vulval ulcer or there is vulval itching, and you strongly suspect that if a GP is seeing and they strongly suspect vulval ulcer, then they will first refer to the cancer center. And in the cancer center, most for the diagnosis, biopsy is taken, and the best type of biopsy is incisional. So this is again asked. Incision for vulval cancer, you do incisional biopsy, and what that means, you take the normal skin also. You take the biopsy from the edge of the ulcer, so that normal skin also comes, so that you can demarcate the extent, margins, and everything. Okay.
Okay. So are these same or incisional is better than the other biopsies?
Incisional for vulval cancer because it is on the skin, no. So
Okay.
incisional biopsy is possible. So you can take it. You take the a part of normal skin along with the ulcer. So you take the biopsy from the edge of the ulcer. That is
Okay.
incisional. So they ask you the specific word, what kind of biopsy you take.
Okay.
It's
Incisional.
yeah. Then to plan for the further treatment, do CT MRI
Okay.
for the staging and all. Then this is a question you want to attempt.
This 65. Irregular vulvar ulcer with raised edges. Itching lower abdomen. Are options there?
No, I've already told. No, if a GP sees and suspect vulval cancer, what will they do?
Biopsy.
No, no, GP never does the biopsy. They will refer.
Okay.
They will refer to the cancer center. Then next question.
Here, like she has been referred, so biopsy.
Yes. And what kind of biopsy?
Incisional.
Yeah, incisional biopsy. This is a staging of vulval cancer. Stage 1, which is confined to vulva.
Okay.
Okay, then it is based on the size. Less than 2 centimeter and less than 1 mm depth is 1A. 1B is more than 2 centimeter and more than 1 mm depth invasion. Then if it goes outside the vulva, from vulva it will go towards the lower part of the urethra, lower part of the vagina, and lower part of the anus. Okay, that is stage 2.
Okay.
Stage 3 is nodes involvement. So inguinofemoral nodes involvement is stage 2, and based on how many nodes and size of the nodes involvement, it is classified as 3A and 3B. 3A is 1 lymph node more than equal to 5 mm. 3A2 is 2 lymph nodes less than 5 mm. 3B1 is 2 or more lymph nodes more than equal to 5 mm. 3B2 is 3 or more lymph nodes less than 5 mm. And if there is extra capsular spread, then it is 3C.
Okay.
Then 4 is distant metastasis, which include 4A, 4A and 4B. 4A is which is local, like upper urethra, upper vagina, upper rectal mucosa, or if it is fixed to the pelvic bone. That is 4A1.
Okay.
4A2 is if the inguinal lymph node are fixed or ulcerated. That is 4A2. And 4B is distant metastasis, including pelvic lymph nodes involvement.
So stage 3 is just inguinofemoral lymph nodes.
Yes, but
Where it's ulcerated.
but see, only lymph node involvement comes in 3. If the lymph node involvement and capsule is also involved, then it is 3C. Okay.
Okay.
Extracapsular spread. If they become ulcerated and fixed, then it is 4A2.
4.
Okay. Then how do you manage? So you have to aim at a tumor-free margin of at least 8 mm, and this is on the fixed specimen. So once you fix the specimen, the tissue contracts. So while you are dissecting, you should aim at getting a tumor-free margin of 2 centimeter. Okay, macroscopic tumor-free margin of at least 2 centimeter you should try. So where the ulcer is there, 2 centimeter of the normal skin also you will remove. That is called as radical wide local excision.
What is this 8 mm for?
See, while you are excising, if there is an ulcer, you are excising. Okay. So you have to, along with the ulcer, you also remove the 2 centimeter of the normal skin.
Oh, along with the ulcer. Okay.
Yeah. Okay. But when you fix that tissue, no, there is contraction of the tissue. So usually 8 mm is the thickness which remains after fixing. So that
here 8 mm is the
in the fixed sample.
Okay.
This you don't have to bother, but you just remember 2 centimeter margin.
Okay.
Okay. Then deep margin of the excision is inferior fascia of the urogenital diaphragm, and if necessary 1 centimeter of the urethra can be removed to achieve adequate margin without compromising the urinary continence.
Okay.
And if lymph node dissection is required, both superficial and deep inguinal lymph nodes should be removed. If the lesion is lateral, that is more than equal to 2 centimeter. Lateralized lesion is if it is more than equal to 2 centimeter from the midline. How this is significant, this I'll be telling you in like further management. So stage 1A, that is less than equal to 2 mm and less than 1 mm stomal invasion. Okay. Then you just do the radical wide local excision, that is you remove the ulcer along with 2 centimeter margin. Okay. No lymph node removal is required here because the risk of lymph node metastasis is very low. It is less than 1%. Okay.
Okay.
And stage 1B is any lesion which is more than 2 centimeter depth and more than 1 mm. Okay. In this you have to remove the lymph node. Okay. And how do you decide which, like you are removing inguinofemoral lymph nodes? If it is lateral means more than 2 centimeters from the midline. Okay. Then you remove only ipsilateral lymph nodes on that side, on the affected side you remove. Okay. If they come out to be positive, then you remove the contralateral. Otherwise, only ipsilateral. Okay.
No. When we are removing ipsilateral, when it is
lesion, the ulcer is lateral. That is more than 2 centimeter from the midline.
Which has to be positive for removal of contralateral site?
The lymph nodes, ipsilateral lymph nodes, if you have removed, send for frozen
Okay,
section.
after examination. Okay.
Yeah. Okay. Median lymph
If it
node.
is negative, we are just going to leave it.
Yeah.
Not going to remove the other side.
Yes. Yes.
Okay.
For median like median lesions, that is within 2 centimeter of the midline, you have to remove both lymph nodes, contralateral lymph nodes, like all both sides bilateral lymph nodes should be removed.
Okay. What is LAD here? Ipsilateral?
LAD where?
Under.
Lymphdectomy, that is lymph node dissection.
Okay. No, LND. Oh, this is also LND only. Okay.
Okay. Okay, so this is called as, if it is median, you do triple incision, you remove the ulcer, you remove both bilateral lymph nodes. So that is called.
What is triple incision?
You give 3 incisions, no? One to remove the ulcer, one to remove one side of the lymph nodes, one to remove the other
Two sides of lymph nodes and ulcer. Okay.
Okay. And any lesion which is more than 4 centimeter, you have to do bilateral lymph node, irrespective of whether it is lateral or medial. You have to remove both sides of the lymph node if it is more than 4 centimeter.
Okay.
Okay. Then about sentinel lymph node biopsy, it is under clinical research only. So sentinel node is nothing. You put a blue dye which stains the affected nodes. And you take the first node which is supplying that area, you take and you examine whether send it for examination, whether it is positive for malignancy or not. Okay. So that is the sentinel lymph node is the first node which is supplying that area. You insert the blue dye which stains the lymph nodes. You take that lymph node, the first lymph node, send it for examination.
Okay.
Okay. So if like in cases if you're planning for whether you have to do bilateral or ipsilateral, if you are in doubt, so what you do, you can send the ipsilateral sentinel lymph node. If it is not detected, then you just remove the lymph nodes on one side. If ipsilateral sentinel lymph node is positive, then you remove sides lymph node. Okay. Then what are the indications of doing sentinel lymph node biopsy? If it is unifocal, confined to vulva, because if it is multifocal, then anyways you have to remove both side lymph nodes, and no point of doing it. If it is primary squamous cell carcinoma, if it is less than 4 centimeter in diameter, because I told more than 4 centimeter, you have to remove bilateral.
Okay.
If stromal invasion is more than 1 mm, because to remove one side or both side is like this option is only in 1A. Okay. So if it is deep invasion, then if the stromal invasion is less than 1 mm, you are not removing the lymph node at all. Okay, so I told you stage 1A, no need of removal of lymph node.
Okay.
So
only when the depth is more than 1 mm.
Yeah, so stromal invasion more than 1 mm, then only there is significance of doing a biopsy. If there are clinically and radiologically negative nodes, because if the nodes are positive, then any palpable or on CT scan you are able to see the lymph nodes, then anyways you have to remove both sides. Okay.
Clinically and radiological negative nodes. So like we are going for sentinel node biopsy out of suspicion.
Yeah. So basically why sentinel node biopsy is done? Just to figure out whether you have to do ipsilateral or bilateral lymph node.
Like how come here clinical picture and radiology will be negative? Oh, for the nodes, it's negative.
Clinical you are not able to palpate the nodes. There are no enlarged nodes. Radiological, you are not able to see any enlarged nodes on CT scan. So that means that. Because if on clinical examination or radiologically, if you are able to see the nodes, then you anyways have to remove both side nodes. Then it doesn't make sense.
Okay.
And then anyways it is stage 3. You have to do extensive management that I'll be telling you. If there is no safety issues for blue dye or technetium 99, because that is used for staining these nodes, and consent has been taken, and follow up every 2 monthly for the first year. So you have to follow up these patients rigorously for the
Actually,
spread.
sentinel lymph node biopsy is on trial only.
Yeah, for vulval seal, yes.
Yes.
Okay. Then post-op radiotherapy for the nodes, the indications include if there is extra capsular spread, that is 3C,
Mm.
if two or more positive groin nodes, or
Mm.
if the margins are positive. Then you
Mm.
give external beam radiotherapy to ilioinguinal as well as to the external and internal iliac.
But you said there won't be any groin nodes here,
Where?
like in the previous slide.
No, this is separate. Sorry, I didn't get your question.
No, like in one of the previous slides, it was mentioned there won't be any groin node
Where?
in, I don't know in which slide.
No. In the staging, I told you, na, if it is stage 3,
Uh,
growing nodes are there.
Invoice of emerald nodes are there in one slide.
In early stage, the lymph nodes are not involved. That's what I
Okay,
told.
only in stage 1A.
Yeah.
Okay.
So, post-op radiotherapy, which all patients you give to the nodes if there is extra capsular spread, if two or more groin nodes are positive or margins are positive.
Okay.
Okay. Then, how do you treat advanced vulval cancer? That is, if it extends beyond the vulva and or if there are bulky nodes.
Mm.
So, how do you determine whether the nodes are positive or not? You can either do FNAC or biopsy, or you can do CT, MRI, PET CT. Okay. If you feel that there is no suspicious of the lymph node by clinically or by imaging, then again, since it is advanced, you have to remove the lymph nodes on both sides. Okay.
Mm.
If it comes out to be negative, then there is no need of post-op radiotherapy. Okay.
Okay. Mm.
And you give pre-op chemotherapy plus radiotherapy followed by surgery. You have three options for advanced cancer. Either you can give, if you feel that it is very much advanced, then
Mm.
you can give pre-op chemotherapy plus radiotherapy followed by surgery, or you can give primary radiotherapy with or without chemotherapy who are unfit for surgery, or you can just do palliative care.
Here, even if there is no suspicious lymph node involvement, we are doing bilateral lymphadenectomy.
Beyond stage 1A,
Mm.
beyond stage 1B, which is more than 4 centimeter, you anyways have to do bilateral.
Okay.
For stage 2, stage 3, stage 4, you have to do bilateral
Okay.
lymphadenectomy. Okay.
Mm.
So option of doing or not doing is only in stage 1B. Stage 1,
Okay.
no need to do. Only in stage 1B, you
Mm.
have an option of doing or not doing, where you do all the sentinel lymph node or ipsilateral.
Okay.
Okay. So that
Okay.
option is only in stage 1B. Advanced, you have to do bilateral only.
Okay.
Okay. Then stage wise management. Stage 1A, I told you, you just do radical wide local excision. No lymph node removal is required. 1B, if it is lateral and less than 4 centimeter, then you do ipsilateral groin dissection or sentinel lymph node biopsy. That's what I told you. If it
Okay.
is median or centralized, then you do bilateral groin dissection or bilateral sentinel node sampling.
Yeah.
Then 1B, which is more than 4 centimeter, again you have to do wide local excision and here you have to remove a bilateral lymphadenectomy. If you don't want to do, then you can do the sampling.
Okay.
Then stage 2, 4A, because it is advanced, then you have multiple options. Either you can do primary radiotherapy or radical surgery
Okay.
and bilateral groin dissection. Here there is no point because anyways you have to remove lymph nodes. So in
Okay.
this stage there is no point of doing sentinel lymph node. So option of sentinel lymph node is only in stage 1B.
Stage 1B. Okay.
Yeah. Otherwise there is no option. Stage 4B, because it is very much advanced, so you can either give palliative care, chemoradiotherapy, all that. Okay.
Okay. No.
Then this slide I have put it multiple times because it is sometimes asked.
Yeah.
What is the survival rate? So you have to learn these figures. For vulval cancer, 1 year survival is 86%, 5 year is 67%. Okay,
Okay.
overall 1 year and 5 year. Okay,
Okay.
then it is also based on the stage. Obviously, stage 4 it is quite less. But at stage 4, 1 year survival is only 43% and 5 year is only 15%. Okay. Understood.
Yes, ma'am.
Okay. Then this question,
Centimeter ulceration above the clitoris. There are no enlarged nodes. It is 5 centimeter, which bleeds on touch. Incisional biopsy.
yes, it should be incisional biopsy. The next question,
Cerebral squamous invasion more than 1 mm. So it is stage more than 1 mm is 1A.
huh? Then less than 1 mm is,
So 2B. No, this is 2B.
why to be put?
Oh, sorry, there is 1B.
No, it is 1B.
1B.
Yeah, it is 1B. Next question,
That is stage 1B. For stage 1B, there is there are no nodes, right? In stage 1, no nodes. So option A.
no, I said only for stage 1A, no nodes. 1B is the one where you have to decide
For
whether it is
for
central or
that
lateral.
is 1B. Oh, that is stage 1B where we decide for sentinel node.
Ah, so this is stage 1B only, no? So what is the answer?
Ipsilateral inguinofemoral
They have
lymph
not given
dissection.
central or lateral. So the best answer, best management plan will be bilateral.
Bilateral, because they haven't mentioned if it's medial or lateral.
Yeah. So what option?
Option E, last one.
Yeah, it is E. Then malignant melanoma. So okay, so about malignant melanoma, most common site of origin of vulval melanoma is clitoral area and labia majora. And what was the most common site for CA vulva? Squamous cell carcinoma.
Labia major only,
Was labia.
90%.
Yeah. Then what is a pre-op imaging required? So CT you have to, because distant metastasis is quite common with malignant melanoma. So you have to rule out distant metastasis, and it is quite the prognosis is very poor if distant metastasis is there. So CT you have to do thorax, abdomen, pelvis, including the groin, and MRI CT of the brain to look for distant metastasis. If major surgery such as excentrative surgery is being considered, then you also do PET CT. An MRI of brain should be performed preoperatively to exclude low volume metastatic disease, as metastatic disease is associated with very poor prognosis, and therefore excentration surgery is likely to be contraindicated. So you have to do all that. Then how do you stage it? So you see here, you see the Breslow thickness, which is basically the measurement of the depth of the melanoma from the surface of the skin to the deepest point of the tumor.
How do we make out this is melanoma from vulvar
By
ulcer?
testing, you will see the melanin pigment. These are pigmented lesions वैसे, but you always do the biopsy to make the diagnosis.
Okay.
Okay. So you see, and based on the biopsy only you stage. So melanoma, if it is less than 1 mm thick, and the outer layer of the which is involved, and it is if it is less than 1 mm, whether ulcerated or not ulcerated, it is stage 1A. 1B is 1 to 2 mm not ulcerated.
Okay.
If 1 to 2 mm ulcerated, it is stage 2A, or 2 to 4 mm not ulcerated.
Okay.
2B is 2 to 4 mm, which is ulcerated, or more than 4 mm not ulcerated.
Mm.
Stage 2C is thicker than 4 mm when ulcerated. So this
Have
is
they
like a
asked
sequence.
questions any of these?
They may ask.
Maybe, but like we have to cram it up somehow.
It's the second most common, no, so that's why I put it here.
But have to memorize all these repeated.
You know, one and two is just involving the vulva.
Okay.
Based on the thickness, you classify 1A is less than 1 mm, ulcerated, not ulcerated. 1B is 1 to 2 mm, not ulcerated. 1 to 2 mm, ulcerated is 2A. 2 to 4 mm, not ulcerated is 2A. 2 to 4 mm, ulcerated is 2B. More,
Mm.
more than 4 mm, not ulcerated is 2B. 2C is more than 4 mm when it is ulcerated. 3 is 3 in all the cancers, ovary, this endometrium, vulva,
Mm.
is 3 is lymph node involvement.
Okay.
Okay.
Mm.
And 4 is advanced stillness. So this is
Okay.
common for all. And 1 is localized to the structure. So if it is uterus, it is localized to uterus. If it is ovary, localized to ovary and fallopian tube. So this is how vulva, 1 is localized to vulva.
Mm.
That's how it is.
So here lymph nodes are involved in stage 3.
Yeah.
And 2C
It's
is
just the deeper involvement.
more than 4 where it's ulcerated, whereas in 2B 2 to 4 ulcerated, more than 4 not ulcerated. Ah, okay, okay, ma'am. Mm.
It goes in a sequence only.
Okay,
Okay.
okay.
So how do you manage it if it is 0 to 1A? Stage 1A, which is 1A is less than 1 less than 1 mm, ulcerated or not ulcerated. So here you take margins up to 1 centimeter, and you can do sentinel lymph node biopsy. You do wide local excision with margins, negative margins of 1 centimeter. 1B to 2A, you do 2 centimeter margins.
Okay.
2B to 2C, more than 2 centimeter margins, both lateral and deep, along with the sentinel lymph node biopsy. 3
Okay.
is where lymph nodes are involved. So you have to do an extensive surgery, and then you can consider chemotherapy, biotherapy, etc. 4 is distant metastasis, so you have to do complete lymphadenectomy, radiotherapy, chemotherapy, biotherapy, metastatic nodes, everything has to be removed. Then how do you manage the lymph nodes? So 1A, you need not do anything. 1B to 3, 1B to 3, you can do sentinel lymph node biopsy. If it comes out to be positive, then you can do completing vinofemoral lymph node dissection.
Mm.
And in case it comes out to be positive, it directly becomes stage 3. Okay, because 3
Oh,
is lymph
if
node
it is
involvement.
positive. Okay. Mm.
Because 3 is lymph node involvement.
Okay. Mm, yeah. Mm.
In this question,
What
what is the stage?
is 1.5? 1 to 4. Stage 1 or 1.5, 1 centimeter margin.
Now, what is the stage first of all?
Stage is the one. This is
1A, 1B.
1B.
Now, what is the stage?
1B
1B. What is the management? How much margin?
or 1B. 2 centimeter.
Yeah. So it could be either 1B or 2A because they've not given ulcerative or not ulcerated. So 1 to 2 mm margin. If it is not ulcerated, it is 1B. If it is ulcerated, it is 2A. But for both, the treatment is the same 2 centimeter margin.
Okay.
Okay.
Mm.
So the answer is 2 centimeter here. Next question.
And what is that Breslau thickness?
Yeah, so that I told you here that Breslau thickness is basically from the depth of the melanoma to the surface of the skin, deep down where the cancer cells are there.
Okay.
Okay, next question.
4 centimeter. Palliative treatment. When there is metastasis.
What stage is it?
4 centimeter. So it is
But आगे भी कुछ लिखा है ना. There is spinal metastasis.
yeah, 4.
Spinal metastasis is distant metastasis.
Yeah, this stage 4.
हाँ, stage 4. A or B?
B.
It is stage 4B. अच्छा, now what is the treatment?
It's palliative only, no?
Yeah, palliative only. So for spinal metastasis, you generally do radiotherapy.
Okay.
Okay. Spinal, brain mets, bone mets, you generally do radiotherapy. Okay.
So this was all about CA vulva. So in the next video we will be discussing about ovarian cancer. Hope you found it useful. Thank you so much for watching.